have this special event thanks to Matthew himself, who suggested it, which I think is incredible. I'm so happy that we get to hear from Matthew, who has been in our program and has made incredible recommendations. And his approach to structure, function, and movement is why his kind of words and the way he presents is always so interesting. And so he's actually going to be coming and presenting in Chicago at our Cadaver Lab event, along with 3 other providers. And I just thought it would be a great opportunity to introduce Matthew. He is here to share some concepts that I think would be really interesting. So that is something that you're going to do. And thank you so much, Matthew. This is more like a gathering on a Tuesday night to hear more.
My pleasure. Great. Okay. So we're looking to kind of prep for this upcoming exciting dissection little presentation that we have coming up in a couple of weeks. And there have been a few things over the years that I've been just sort of kind of lurking in the corners here of all of our office hours and clatches related to myofunctional therapy that I think from the vantage point that I have as a manual therapist. So Samantha gave me a nice introduction and I dropped right before I heard it all. So just to make sure we got the bases covered. So a lot of my practice, in addition to being working primarily with connective tissue as a Rolfing structural integrator, I have extensive training working with visceral, vascular, neural, and cranial and joint capsule tissue. So looking more specifically at different types of connective tissue beyond just fascia. Fascia is a nice sort of trendy term that gets tossed around a lot and sort of, describing all of this connective tissue as fascia. And from a sort of a strictly anatomical standpoint, that's not correct. Fascia is one form of connective tissue, and we want to think about connective tissue as sort of all of the kind of stuff that holds the body together, kind of wrapping around cells, wrapping around groups of cells. And it's a kind of like a three-dimensional spiderweb matrix that has to physically move as we move through space. The body's mostly fluid with, water having to circulate around in the body. And so all of these different layers of connective tissue have to be able to move with one another so that the force of using the body to circulate those fluids can happen, and also the forces that we subject ourselves to by using our body and through the force of gravity through our body, those forces can efficiently travel through the body without running into little roadblocks or interruptions. And when we sort of live life and do interesting things, or interesting things happen to us, we can frequently find ways where, as those layers of tissue start to repair, the um, capacity for those tissues to actually allow force to move through them changes. So the basic thing that we're looking at when we're looking at connective tissue, fascial tissue being one form of that, is that tissues need to have the ability to glide and slide with their neighboring layers. And one of the ways that we can lose functioning is that tissues can develop little fascial or connective tissue adhesions, are little cells that lay down fiber in the body. Fibroblasts respond lovely to little usages and injuries and are all constantly remodeling the body. And so we can develop through bumps and scrapes and infections and surgeries and other such things. We can develop little, what look like when they first start out, like little fine cobwebs between layers so that layers do not slide effectively or as effectively as they once did. We can also get disruptions to the stretch of a layer. So if you kind of see my shirt has a certain amount of elasticity to it. But if this was living tissue and I bumped and scraped it up and it got thicker, that elasticity would be less. So if we try to put force or movement, ask that tissue to move, it's not going to be as adaptable as it once was, or, based on kind of the original design. So when we're looking at things from a myofunctional standpoint, we're, looking at how function in the oral complex is going to be potentially affecting lots of different areas in the body. And one of the places that I have kind of noticed that we could potentially, as myofunctional therapists, kind of have a better understanding of how what we're looking at up here in the kind of oral complex, how this is very tightly related to what happens in the thorax with breathing, with lungs, and how lungs actually move. Because most of us have got to breathe all the time. And lungs, they get roughed up. I mean, all of us here have had, multiple colds, coughs, flu, probably many of us have had a case of bronchitis. Perhaps some of us have had pneumonia or more than one. We've had auto accidents. We've had, falls, blows to the chest, possibly broken ribs. Lots of interesting things can happen, even just through the course of, say, pregnancy, and, late term, if the baby's kicking mom's ribs, those can be things where they get, tissues on the inside can get injured and as a result, lose some of the elasticity. So what I thought I would do today was basically kind of review some of these movement relationships that are critical for not only being able to breathe, but also looking at how those tie in with the ability for shoulders, neck, and everything else to move. And it's kind of being able to expand on that in more detail during our upcoming sort of dissection adventure lecture in a couple of weeks. So the basic gist here is that because breathing is important, as we are breathing, the lungs have to physically slide. They are getting bigger as we inhale, we hope. And as they do that, they have to slide. The outside surface of the lungs has to slide on sort of the inside wall of the ribs. And many times we can develop interesting little fibrous adhesions and other things that will reduce the glide of those three-dimensional kind of the two lungs. You have a three-dimensional surface all the way around, can reduce glide in multiple places. Once that happens, and it happens in everybody, I can guarantee you everybody here has got it to some degree. I see it in every patient that I work with. They're just a natural part. You get a cough or a chest cold, something that goes deeper down in, and it's a guarantee as you're coughing to try to get stuff out, you're going to be roughing up some of the layers here. And I'm going to show you some slides where we can it's helpful to get some pictures in your mind of three-dimensionally what's actually going on beyond just sort of the muscles and the fascia around the muscles. And this is primarily because lungs themselves are extremely delicate material. They're very fine, kind of squishy, watery, spongy material. And if they get themselves stuck to the kind of outer meat suit of the rib wall, as we breathe, as we try to do more vigorous Buteyko breathing, as we try to twist and move or yogi ourselves into stuff or whatever it is, we could we're moving the body three-dimensionally, twisting it like imagine if you were kind of wringing out a washcloth. That force is going into the lungs, and if the lungs don't have enough room to glide and slide, you are going to be putting yourself in some potential dangerous situations. The body's kind of intent on sort of staying alive. And so generally what you will find is that the body will recruit lots of interesting little bits of muscular contraction to say, excuse me, do not do that. You will feel that many times and have stories of, oh, here my shoulders are tight, my ribs are tight, can feels like there's a gorilla sitting on my chest or something like that. I can't take a deep breath all the way down into my diaphragm, sort of my diaphragm isn't engaging fully or something along those lines. And many times, a component of what's creating those tension patterns are restrictions in the ability for the lungs to be able to effectively glide and slide on the ribs or on the diaphragm or anything three-dimensionally within that space of the thorax. because these tissues are also connected all the way up into the neck. If we, I won't get into it today, but we might be able to get into it a little bit if there's interest in the lecture when we do the dissection. From an embryological standpoint, there are continuities of some of these connective tissues all the way up into the front of the throat, in front of the spine, through the throat, and right up into the base of the mouth. So that if we have restrictions further down in the thorax, it's basically pulling down, you're not going to be able to get full expression of the tongue up onto the palate because you have restrictions further on down. And you can do your exercises till the cows come home, and it's going to be a really slow way to get that change. So if you can, many times, if you can kind of get to the sources of some of the issues, or at least at the very least from a mild standpoint, be on the lookout for certain things in a person's health history. So most people coming in sharing, oh yeah, I've had a couple of rounds of pneumonia. That would be a red flag. I've had a couple of auto accidents, or I had a fall and, I played contact sports. There could be things that you could be kind of incorporating into your intake form, that could sort of raise a little flag so that you then know, aha, this might be a person where it would be beneficial to bring in some of the other people in your sort of treatment circle to make sure that you can actually expedite the change you're looking for from a, sort of the kind of exercises from, the mild functional standpoint in helping to improve that function by getting closer to the sources of some of those issues. So, I just said a lot of words. So if I continue on, if people have questions, I'm just going to encourage you to just raise your hand and fire away. And I'm going to shift into some slides here momentarily. So I just want to make sure, did anybody have any questions about everything I just rambled through there really quickly?
You're saying that if you have all of these adhesions in the lungs with the ribs, it affects, upwards. Can the opposite then also be true? Can injuries here then affect how your lungs and your
That is a great question, Nikki, and I'm actually going to
ribs
post,
are coordinated?
there's some additional links in how those tissues, so if we have, particularly if there's been whiplash type actions or injuries to the head specifically, contact sports are great for this, jamming your jaw into something is great for this. Because of some of those connections, those will oftentimes reverberate down into the thorax, particularly looking at some of the tissues. There's lots of times we're talking about kind of vagal tone and vagal nerve, function and things like that within the clatch and other things. So there are actually branches of the vagus nerve that are traveling down to both branches that go to both lungs and the heart. So you can have mechanical strains in that nerve, or some branches of those nerves, to different portions of the lungs, and those usually go hand in hand with other restrictions that you find in the layers of the lungs. So I don't want to kind of get into too much of the anatomical detail, but yeah, there are pieces both up and down. And usually it's not sort of just this one piece and this is going to fix everything. There are usually multiple layers. But in terms of helping to create sort of noticeable change for people so they can kind of feel a sort of a pre and a post of, wow, I can actually take a fuller breath, or wow, I can actually move my shoulder. Generally, when working with people, I'm kind of, there are things closer to the surface that as we're sort of peeling the layers of the onion away, you can start to help people feel the contrast in that function relatively quickly by kind of looking at some of those glide planes. And this is some of the stuff that I'm intending to kind of demonstrate during the dissection lab, because we will actually have a treatment table. And I can show you, how in relative short order, once you can kind of address those different layers of tissue, they're relatively easy to, for lack of a better term, unstick if they are adhered. It's kind of, oftentimes they'll have Velcro, and I'm going to show you a video of that so you can kind of get a visual of what some of those things actually look like on the inside. Because most of us, unless we've studied extensively with anatomy, we don't necessarily are walking around with a picture of what's actually going on three-dimensionally on the inside. Did that answer your question, Nikki? Cool. Anybody else have anything?
Jenny.
I get the thorax and the fibrous tissue formation throughout the body from trauma. I understand that. As a rolfer and working on connective tissue yourself, what is your opinion? I treat a lot of Ehlers-Danlos patients, but they have to treat them carefully. Does your work as a rolfer increase, and English isn't my first language, so I'm not going to say it correctly, hydrolonic acid for the slide and glide that you're referring to?
That's you, Jenny. You bring up a great sort of subtopic question, and I could spend a whole hour talking about this. EDS patients, Ehlers-Danlos, there's more pieces to this. Generally, with EDS, this is even if somebody has had a diagnosis, it doesn't present uniformly throughout the body, and so people generally with that have certain areas that have greater mobility and sort of a lack of functional tone, and other places that don't. And there are some pieces of that that are kind of on a different topic that I'm also passionate about in terms of looking at some of the sleep chemistry that's directly linked to that, in my opinion.
Thank you.
But yes, so there are ways that you can skillfully EDS patients are generally you have to be extremely careful with how you work and gentle with how you work with those individuals. But they all have every EDS patient that I've worked with has a robust array of fibrosities
Yes.
in certain areas of the body that have to be effectively addressed to improve function.
But I've had rolfing. So my question is, you as a rolfer,
Yeah.
you said you're manual manipulate, whatever.
Yep.
Do you see that increase in slide and glide? Do you feel that it increases the hydrolonic acid? Okay, thank
Well, I
you.
can't speak to the hydrolonic acid, but the glide in loose areolar tissue and whatever the layers are that I'm addressing, yes, we
Okay.
can see it regularly. But with them, then generally there are components to be able to ensure that they can actually integrate the input that we're getting within sessions. Being able to optimize their deep sleep and REM by working on their sleep chemistry is absolutely critical. Otherwise, the traction that they will have between sessions is limited.
So you base it on symptomology. They get better, they have better range of motions, they can use their extremities, they're out. We don't know the hydrolonic acid increase, but they have increased motion.
Yeah, I'm always looking at functional. Yeah, when I'm assessing a particular area that's not moving, where many times, things through joint capsules, glide and slide of a neurovascular bundle, long pieces through there. Yeah, there are plenty of places where you can actually palpate and find that there are layers that are adhered and deserve to be sort of treated in a way that will improve the glide through the layers or elasticity within a particular layer. Did that answer your question?
Yeah.
Yes.
Beautiful. Okay. Is there any other questions? Okay. All right. So let me see if I can.
We go with first Gail. I'm seeing you.
Hi.
Go, and then
All
Caitlin.
right. Thanks, Sam. Yeah. Hey, Matthew, I have a sleep study coming Sunday. I've never been able to get my tongue up on the palate to stay there. So is there some questions I should be asking that goes into this sleep study? Should I be taking the results and bringing it to somebody that's a rolfer?
Well, we might have yes. So a couple, I want to back up a couple bits. So yes, I have training as a rolfer, but if anybody has experience with rolfing in general, the type of work that I do is very atypical of your standard rolfer. Most rolfers, are working in a sort of a heavy way with pressure to release fascial tissue. That is not what I do. My work is much more manual therapy. It's much lighter in contact and much more anatomically specific. To your point about the sleep, the main thing I'm usually looking for when I'm bringing in a lot of the information from Right Sleep with the PSG is what's actually going on beyond just if they're going to be looking for potentially what your with the apnea hypopnea is coming up at, but I'm always much more interested in what's happening with the REM.
Yes, and I have fibromyalgia.
Aha,
And
good.
no one ever asked me about what I did for work. And I did my work leaning on my left side, and all my fibromyalgia is on my left side.
Okay.
So I think the connection should be connected, and I'm trying to learn your connection now. It's very interesting, Matthew. Thanks for coming.
Yeah, so I would generally with fibromyalgia and other sort of chronic issues of that nature, there are components with that I'm seeing with the efficiency in sleep cycling. And so by kind of restoring some of that underlying ability for the body to actually repair by spending more time on the clock, that generally those conditions will improve, and also the manual work that I'm doing with patients generally sticks better because people can actually make more repairs between sessions.
You're leaving your information with us?
Yes, it was at the bottom of my slide, but I
Okay.
don't have the settings correct, so I would have to leave and go back in. So
Why
I
don't you
can.
leave?
It's okay, we can wait. Yeah.
Okay.
Wait.
All right.
And then you're different than somebody who does Reiki?
Yes. Yes. Well, potentially. I mean, there are lots of different types of Reiki practitioners, but yes, the work that I do is much closer to a traditional osteopath. Okay, let me
Thank
leave
you.
and come back in and we can watch the slides and I can show you some of the videos of actual lung adhesions and then we can go from there. So be back in a jiff here. Hang on. Okay, so we are again we're looking at these layers, and this is just key. So here's a cross section of our just generic lung here, and so the particular glide plane that we are looking at is between here. If you can kind of see with my cursor, kind of coming around with this zoom in of the lung and the ribs. So it's been kind of blown up for dramatic effect here between the lining of the lungs and the inside lining of the ribs. This is only, a couple of molecules thick of fluid, a serous fluid. And so as you're breathing, the diaphragm is attempting to contract. And so the lung is being stretched in an inferior direction. And as that happens, the lung is sliding along the inside surface of the ribs in a mostly inferior direction. So there's more movement at the inferior portion of the lung than there is at the kind of the superior aspect of the lung. But the thing to kind of keep in mind with this is that when we're looking at uh, sort of the layers of musculature, and I see this regularly when I'm working with other manual therapists or massage therapists or whoever else. Sort of the stories we tell ourselves about why the muscles, common one would be sort of looking at shoulders, neck, all these things that are tight. When we actually look at sort of the actual depth of the musculature, even in large, well-muscled men, we're not talking about that much depth before we actually get into lung proper. So many times the tension that we feel inside those shoulders, if I ask somebody, oh, is this something that you feel, is that at the surface or is it deep? And if somebody is saying, oh, it's deep in there, that's a dead ringer for an adhesion restriction between the layer of the lung and the layer of the ribs, between the visceral and the parietal pleura. And if everybody here, as you're sitting here, if you just take your fingers and find your collarbones, and you take from your collarbones and just kind of slide sort of as you were going to go sort of back towards the tops of your shoulders. It might be minimized here because I got the presentation on, but if you go just kind of back above your collarbones a little bit and just gently sink down a scooch. As you sink down, you're going to feel at some point you start to get a little denser. That's apex of lung. It's not that deep in there. So when people are looking to kind of open up movement for breath or open up movement for their neck, a lot of these restrictions through here are going to cause all these muscles to tighten up to protect because the lungs are delicate. So further on with the slides here to kind of get some more visuals of this, here's an even more blown up version of it. And it's a cross section we can kind of see of this, again, this space where there should be serous fluid so that it creates a little slippy slidey glide plane. And then we have a cross section of ribs with the corresponding bits of intercostal nerves and arteries through there. So if this is a good example here where that's particularly on the sides of people's torsos here with the ribs, you're talking about a very thin amount of tissue before you are into these layers of the lungs. And of course, as we get lower down towards the diaphragm, this is exactly what you have, is these different layers that are, pretty darn close to the surface that can be restricted. Like I said, I mean, it's a rare person that I find initially who I haven't worked on who doesn't have some degree of those restrictions, which will affect how the diaphragm is actually able to move. Because if it's trying to drag the lung down and the lung can't slide, you're not going to go very far. This is one of the things we run into with our Buteyko breathing, is that just these restrictions in glide. Here's a cross section of the lungs, kind of like you can sort of see in the upper portion here, sort of upper thorax cross section, just to kind of give you another viewpoint of the space between lung and ribs. Again, it's kind of blown up to dramatize the space between. There shouldn't be that much space between. These two are immediately adjacent one to the other, and there's a thin layer of fluid where that slip and slide, that glide should be. But in addition to this, there's another piece here that's helpful to notice here, to getting back to, I think it was Nikki's question about connections up into the neck. So if we look at the front of the rib cage here at the bottom of the slide with the sternum, and we can see that around the inside portion of the lungs, we have this space for the heart. And there also needs to be a glide plane between these two surfaces. And these are the membranes that will continue all the way up into the front, kind of on the lateral aspects of the vertebral bodies of the cervical vertebrae going up and through. So when people incur interesting little whiplashes, you're going to get those movements going directly down into the thorax, in various angles and directions, depending on, what position they were in when they got, hit, whether it's auto accident or contact sport or falls or things like that. This is another slide to kind of just give a sense of, from an embryological standpoint, I'm not going to get into too much detail of this, but as I mentioned, if there's interest during the presentation in Chicago, we could do this. But in the first sort of generally kind of like 28 to day 43 of gestation, the lungs, what will be the lungs, are actually growing down and into the space that then eventually makes up the rib cage. And so this lining that we're looking at, as you kind of see in the progression, as the lungs branch and grow in, this is eventually what creates, in this bottom portion down here, this continuous little slippy slide, we hope, glide plane around and through. So there should be, the only place where the lungs should be attached to the actual rest of the tissue should be right where the branches come off at kind of towards midline, and everything else should have a glide plane, but frequently they do not. And that will impact movement, articulation, rotation, breathing, lots of different pieces that, we are generally looking at in conjunction with our myo. And let's see the next slide. So here's that cross section and a different vantage point, so we can kind of see the little yellow dotted line. This is this kind of mediastinal space where these two membranes are, and they're going to continue all the way up, as I mentioned, into the front sides of the bodies of the cervical vertebrae. So when we have those snaps to the neck, these are forces that are going kind of in a longitudinal-ish direction, superior to inferior, depending on the direction the head is being jostled when, you are abruptly coming to a stop. And here's the video of an actual pleural adhesion between the lungs. So this is a cadaver. So getting ready for our cadaver lab, if you're squeamish and you're not planning on going to it, you can just turn away if you don't want to see bodies. But we're going to be seeing this lung actually being inflated. And where the cursor is, this is a pretty robust adhesion. They can, be smaller, but I'm going to hit play, and I want you just to see, the mechanics of what happens here with this restriction. So this little spiderwebby matrix right here in the middle, as they're expanding it, you can see that little pull. That is not supposed to be there, and that is impacting. If this was a living individual, this is going to impact how easily the ribs are going to be able to elevate and the lungs are going to be able to slide down because these two are stuck together. Not good for, being able to breathe. Pleural adhesions are so common that if you were to ask your physician about, pleural adhesions, they would probably tell you not to worry about it because they consider them, most physicians and the medical establishment considers them a normal part of aging
So it
because they
said
find them in everyone.
infections could cause that, or
Yep, any kind of inflammatory event, an impact event, sort of exposure to, chemicals, things there. There's lots of different things that, could be sort of planting seeds. The lungs are literally, the inside of the lungs are literally exposed to everything on the outside air. So hopefully if we're breathing through our nose, we're filtering and priming that to some extent. But of course, we know as, myofunctional therapists that they're coming to us because they're not breathing through their nose. So as a result, yeah, we can safely assume that we're going to have an abundance of these. And this can be either on the outside of the lungs with the ribs, or didn't have time to get into it today, but we can even have a change in the spongy quality of the lungs themselves. And that's very common with bronchitis and pneumonia, where the lungs themselves, they should be, if you kind of, the analogy I'll usually use for people is, if you think about a spongy quality like I don't know, some sort of a kitchen sponge or something, a new one, you just got it, took it out of the bag or the box. It's nice and soft. You're replacing the one that's been sitting there for 6 months. That's a little stiff. When you have, tissues that have been roughed up through some sort of infectious, that's what you're going to have. And once you free up the glide between the ribs and the lungs, you can then kind of work deeper in more effectively and you can feel it. Some portions, the lung is actually subdivided into different subsections. It's not really just a left and a right lung. You've got basically, most people have sort of 3 sections or 3 lungs on the right and kind of 2.5 on the left. And you can check those individual little pie wedges of lung lobes and you can feel it. Some will be softer and squishier and some will feel like bricks. And when you have those restrictions, oftentimes those are things related to some of the fibrosity in the spongy matrix itself. Those can be restrictions to the vasculature to the lungs because of course the lungs have a robust amount of vasculature to help with gas exchange. It can also be branches of the vagus nerve that go to each one of those lobes of the lungs. So there are multiple options of how we can get ourselves further stuck as we're kind of peeling the layers of the onion away to open up more functional space for breathing, because breathing should be easy. Those tissues should just sort of softly move. We shouldn't have to work at it. And if we're working at it or putting a lot of force into it, we have a risk of over leveraging some of those tissues and kind of roughing them up. There is a distinction in the sort of any of the visceral membranes, any of the tissues that wrap around organs or other, more things that aren't specifically kind of muscular fascia. They're a little more delicate and they don't like to be worked too heavy. So you really have to be gentle with them because if you're too aggressive, you can get change, but generally what will happen in the process is you're working a little too fast and you will sort of irritate the tissues a little bit, which will activate the fibroblasts and they will come back and lay down more fiber. And so you kind of get in this little sort of hamster wheel, round and round you go, where you feel better, then you don't, then you feel better. So this is many times, if I'm working with a patient, I will oftentimes ask them if they have received other types of therapy, how long did you feel better?
can I ask you to play that one more time so we can just
Video? Absolutely, sure.
Mhm.
It's kind of
And
cool, huh?
it's super cool. And of course, the questions around, we'll go into it.
Let me see if I can get it maximized here. Slide. Here we go. Yeah. Okay. Here we go. So right there, you can see that. Can everybody see that this little piece right here? And that, like I said, that's a pretty robust one. Many of the smaller ones, once you're talking about a fixed body and going into tissues, it's been cooked. Some of the nature, and we're going to see this in Chicago, is that the tactile quality of the tissue is going to change once the cadaver has been preserved. So a fixed cadaver is it's going to be like a cooked piece of steak. It's not going to have the same malleability that a living piece of tissue would. So it can give you some information because, of course, it's not going to decompose as quickly, but there's some pieces of information you're not going to be able to discern from it because the protein structures have changed because it's been chemically altered. So, you have to kind of always keep that in mind, is that living tissue isn't going to necessarily look like this, but we can start to get a functional sense of like how these things are actually supposed to be able to move. So yeah, so we're just kind of showing that adhesion kind of in the lower, and then as they inflate the lung here, you can see how that stretches it further, pieces through. And of course, they're pulling some of the lateral aspect of the thorax away to demonstrate that. So for most people with some of these restrictions, you could be clipping along and just say like, I feel fine. But of course, and also, hey, my lung capacity isn't what it was when I was 22. Like, yeah, because you probably have a collection of these, and so the amount of space that you have to move on the inside is significantly smaller. So there are ways that you can kind of do we want to see it again? Are we good?
We're good. That was incredibly fascinating. I have so many questions related to kind of the sequelae of what you were saying. Like, oh, you have a classic myofunctional disorder, and mouth breathing bringing in the higher risk for infection, inflammation.
Yep.
Then you add other aspects that I'm curious about, which is how does this affect oxygenation? And
Oh yeah, because you're not the most common place for these restrictions to start to show up is in the lower lungs because of some of the I'm going to more of this detail in the lab in Chicago because I can actually demonstrate it. But how the diaphragm actually, with respiration, where the diaphragm sits at an exhale. There's lots of artistic license, shall we say, in terms of depicting, what lungs and diaphragms look like and how high the diaphragm actually comes up on a full exhale. When it's fully relaxed, it's immediately adjacent to the inside wall of the ribs. So rib to diaphragm adhesions are incredibly common. And once you have those, the lungs will not be able to, the diaphragm will not be able to pull away effectively from the ribs. And this is one of the pieces that we're mentioning. I'll just kind of put it in here. One of the telltale signs for a costodiaphragmatic recess adhesion, so this adhesion of the ribs to the diaphragm, is flared ribs. If you see a patient with flared ribs, that is a dead giveaway that they have restrictions there, and to seek some prompt assistance with that, because those are robust enough that with multiple repetitions of breath, 20, 25,000 times every day, that those lower ribs are mostly cartilage on the anterior aspect. That's usually where they show up. And over time, the diaphragm, it's trying to breathe, it will actually torque that cartilage and cause it to flare out. So once you free up those restrictions, generally within 6 to 8 months, usually, things will start to become more flush and contoured with the rest of the ribs in the front.
Caitlin, you have a question.
Yes, hi, I have a question. I have very flared ribs, and I also have had 2 total jaw joint replacement surgeries. And I'm just curious, and I have scoliosis and kyphosis, and my surgeon thinks I might have EDS as well. So I'm just curious how, well, so I had a disease where my jaw joints were degenerating over time. And so it was closing off my airway. So I'm wondering what led to what, and because a limited airway can lead to all these other postural changes. And I'm curious, did that cause all of the adhesions and all of that? I don't know. I'm just mentioning it because it's interesting, fascinating.
That I would love to be able to respond to that, but I know I'm going to run over time if I do that.
Yeah, I know.
As anybody who's been in office hours long enough knows, I chime in frequently with pieces related to sleep. and right sleep. And there, my in little synopsis piece is, my suspicion is that a lot of these pieces, pretty much everybody that comes to Mayo is coming because there was if it started, if there was something going on early on in development, in your life,
Yeah.
were chemical deficiencies in development. So look to what's going on with the mom, and usually you can trace these things through the lineage. And,
Yeah.
and if we have those pieces, the good news is that these are things that are potentially changeable by giving the body back more of the things that it's looking for and give it more time on the clock to sleep to make those changes, in conjunction with usually getting, some manual work to help facilitate opening up more space to actually, move. Movement's
Hmm.
kind of key. We want to be able to do that. So
So you're saying that this can be treated.
I'm doing
With
it.
three.
Yeah.
Exactly. No, I mean, this is why, I mean, it's just so, to look at a myofunctional disorder from this and through this lens
Yep.
is like, it's the other way around.
Right. I mean, because we're looking to help people, and they're coming to us with issues, and we want to hope. I mean, ideally, we want to help them sooner than later. So the more we can get to the sources of the issues, so that their bodies can actually heal and change, I'm all for that. So if we can bring in other tools that are more pieces of the puzzle to help complete those things, I mean, I'm game for that, and most of my patients are too, because it's a, hey, wow, I mean, either in terms of the change that I'm seeing between sessions based on what I'm used to, or what the person's feeling, and usually it's, hey, I feel better, or things along those, or other ways that we can track it to say, hey, I can lift my arm up now and it doesn't hurt. I'm like, cool.
We have some questions in the chat.
Sure.
How does a Rolfer identify these restrictions? Does it require scans or is it a tactile evaluation?
Okay, so again, I want to clarify with this. Most Rolfers are not going to be doing what I'm doing. I've got, in addition to my basic Rolfing training, close to probably 3,000 additional hours of training, training in visceral, vascular, neural, and cranial and joint capsule. So it's well above and beyond what your normal Rolfer is going to get. There are Rolfers or structural integrators who have that level of training, but they are few and far between. So your average Rolfer, if you were to search on Rolfing, you're probably not going to get this. You might get some beneficial work in terms of connective tissue, but not a lot of the stuff that I've been talking about. So I just want to make that
Right.
piece clear.
So you oftentimes recommend different places to go find.
Yes. If you have a question, so the resources, if you have a question about trying to find somebody, I would say probably a couple things you could look for would be, you could just reach out to me. I'm, just like in the office hours, I'm happy to help, because some of these individuals are hard to find, and it's not just sort of like look for this particular credential. Probably the best resource that you could, or the two best resources you could look for, with the stuff that you regularly mention there, Samantha, would be the Cranial Academy. If you're looking for a cranial osteopath, if you're in the States, chances are they're going to have the skill set to address some of these, but possibly not. I have seen patients who have seen an osteopath, and they missed a lot of stuff. So it could happen. The other resource would be the Berean Institute. They have in North America and elsewhere, they're sort of the kind of the main training body for visceral, neural, and vascular manipulation, more of this or subtle osteopathic type of manipulation. And they have a directory with anybody that's taken their classes. So what you want to look for on the directory is somebody that's taken all of them, or the majority of them. They'll have a listing, in terms of, say like cranial sacral and visceral, and you'll see how many modules that are available and how many the person has taken. So just try to find somebody that's within, 200 miles of you that's taken lots of them. And then contact them and ask them how much of their practice is actually this manual work. Because just because they've taken those trainings does not mean that they've actually integrated it. This work is really, it takes a long time to develop the palpatory skills to actually do it. Usually a good decade or more. So just because somebody's taken a bunch of classes does not necessarily mean that they're actually practicing it enough to be proficient to actually be able to, assist before you start sending your patients to them. And then with that, generally, if I'm going to try to refer other patients or family of patients and elsewhere, I either try to, screen the person, check them out, or if it's local, I always make sure I can experience the person firsthand before I send them, because there can be a lot, it's like any practitioner, and it's like there's mild practitioners, and there's others, there's chiropractors and there's chiropractors, there's PTs and PTs. So the skill set can vary, the philosophy that they're taking can vary. And for a lot of this subtle tissue, you really do need someone that's got a very refined skill set to be able to work with these effectively. But once you have it, you can really do some really cool stuff to help people in a relatively, short period of time.
Okay, anybody else have any questions? Let's see. We have a few kind of also in the chat, but I think you must have covered it. Nikki was talking about after pneumonia. Is this something that can be?
Oh, good question. Yeah. So with respect to anybody who's got sort of an active or relatively recent respiratory infection, some of this work is definitely contraindicated, because the body has got a full plate with just trying to recover from said insult. So usually I'm, waiting maybe a month or more. It depends on the person in terms of, if they're still actively coughing, then I might be proceeding with extreme caution, because what we don't want to do is make things worse by treating when their immune system is still actively trying to clean stuff up. And me going in there and trying to, hey, let me help out, is like, hey, no thanks, get out of here. And usually, if you do that, especially when you're working with visceral tissue, you'll flare them up, and they won't feel good. So I try to avoid, making my patients feel worse. So I'll just tell them, I said, or if they had surgery, say, come back in 8 weeks. I can work on some other part of the body, but I'm not going to be mucking around in there while you're actively remodeling that. I just had a knee replacement. Can you help me with me? It's like, we'll look at other stuff, but I'm going to steer clear of that until things have calmed down.
Yeah. Jennifer.
Hi, Matthew. Nice to see you.
Hey,
I
how
haven't
you
seen you in so
doing?
long.
Hey.
Yeah. Couple questions I have is one, and I
Sure.
don't know if you already said this, maybe I missed this, but when you think you have some of these adhesions starting to clear, how
Yeah.
do you assess like the mobility again of this rib cage? Like, do you have a protocol?
Oh,
And then the second thing is, there's this group that is like stretch to win. So it's like fascial stretch therapy. You'll see it a lot through like fitness trainers and stuff like that. How adequate is that for this, like, passive where you're laying on the table and these people are stretching you? Like, compared to everything that I know and what you're talking about, like, how effective is that? If someone says, well, I go to fascial stretch therapy.
Oh, Jen, you're so smart. I love that question. Okay, so a couple things with this. So yeah, there are multiple ways when I'm working with a patient where, I'm over a period of time. I mean, I'm looking at the body as a whole system. So I
Yeah.
have different assessments that I'm using to see kind of what's coming up on the agenda at any point in time. That's going to be the most fruitful to work on to create change in the whole system, as opposed to somebody coming in saying, hey, I can't breathe and my shoulders hurt. Can you work on that? I will say, oh, yes, that's very good, but we're going to look at everything else, because oftentimes by addressing something in their knee, what do you know? They can breathe better, because we're looking at structurally how those forces are moving through. And just because generally pain or discomfort is a poor indicator of what's most primary in the body to actually most productive to work on. Sort of the tip of the iceberg. It's a we want to know what's further down that chain, because if we address that, it'll cascade up. And generally, we don't have to work as hard. I'm looking for the most change with the least amount of effort, because I'm lazy.
Yeah.
So so where can we work where we can get the most cascaded change? With respect to the, but in terms of addressing, assessing the mobility of the lung, yeah, we want that, as I demonstrated in those slides, the whole circumference of that lung, all that needs to move. And
Okay.
so over the course of multiple sessions, we're just kind of chipping away at it. But there's only going to be so much input that you can put into a certain bit of tissue at any point in time before it says, I had enough.
Yeah, I was gonna say I had
If
enough.
you overtreat it, you flare it up. So
Yeah.
it's, I mean, I try to tell people it's no different than if you were doing a workout, if you were doing yoga, if you were doing meditation. You get a sense of when your body's like, I'm done.
Yeah.
If you try to do more, generally it does not go well. So
Yes.
listening for those pieces to kind of titrate the input so that you don't overload their nervous system. With respect to the breathing, it's the same thing. So any kind of mobility that people are attempting to do, yoga, any kind of active piece, this is a tough one because we're oftentimes inclined to, we're impatient and we want to we identify something, we want to get to it, kick into
Yeah.
terror mode and just go. So generally what I will advise people that I'm working with to track is the contrast in their breathing. If they stretch, if they do anything, if they come from a baseline of what does your breathing feel like before you do the mobilization, as you start to mobilize, there is going to be at some point a subtle little change in the openness and the ease of the breath. When that first hint of diminishment of breath occurs, stop. Stay on the soft side of that. This will help your nervous system. You're looking at this balance between sympathetic and parasympathetic. As you stretch more aggressively, what you are creating is more of a bracing kind of kicking into a little more sympathetic fight or flight. And you've got this
Mm.
going on inside the body. So, I mean, if you're fond of banging your head against the wall looking for change, be my guest. But if you want long lasting change, what you want is a nervous system that is open and receptive to this input. And so you have to pace it at a rate that this body can actually integrate this. Think of it like it's like basic relationship dynamics, the stereo male female piece of like, let's find a little subtlety here so we can actually communicate in a way
Mm-hmm.
that's more effective. So what you will generally find is if you slow down and just come up right to the soft edge without going over it, then at some point, hey, what do you know? That edge moved a little bit. And then you can go a little further, and then the edge will come back, and then a little further. So initially, it's going to feel like you're not doing anything. But what you really want to look at, and I ask this people when they're doing stretching or whatever, yoga, whatever it is great. How'd you feel the next day? Oh, I was tired. I was I got to do it every day to stay loose. I was like, then that means you're overdoing it. There's something about what you're doing that is stirring the pot. What you should have is, I mean, same with yoga, with working out. If you kind of, after you get over the initial, hey, I'm just moving my body. If it's sort of, I feel good for the day, but when I go to sleep and I wake up the next morning, I'm stiff and sore again. Some part of this, how you're dosing this input into the body is not working. And as
Mm-hmm.
you're sleeping, your fibroblasts are going to town saying, who came through here and roughed all this up? And so they're laying down fiber every which way, and you wake up feeling, you got to move again. And of course, there's a component of that that's also linked in with right sleep and pieces of chemistry, but I won't get into that right now.
I
But
do
Okay.
have a
your
quick
question, Jen?
Yeah. Awesome. Thank you.
Cool. You're
We're
welcome.
coming to at the end, but with people who have paradoxical breathing or in these sleep apneic events and these movements, is that something that could contribute to these fascial adhesions that you're seeing? Or is it different?
Yeah. I mean, so if you get far enough to the point where you're having apneic events, I mean, you're far enough down the path where you're going to have mechanical restrictions, you're going to have chemical deficiencies, you're going to have multiple things that are feeding one upon the other. And so then that's where kind of I'm bringing in sort of a multifaceted approach to address more of the variables to be able to create more of a lasting change by we've got to make sure that the body's got space to move and then also has the resources to make the repairs when it's sleeping and enough time on the clock when sleeping to actually get the job done. And if we can bring more of those pieces in, generally what I have found, and I'm very surprised with some of the changes I've been seeing with people who have, kind of integrated some of the elements of right sleep as we're going along, is that, I mean, we're getting much more change than I would, historically have seen. I'm telling, oh, this is going to take 8 months in the course of a couple of sessions. It's pretty amazed with how much their bodies can run with once they actually have the raw materials to and the time on the clock to make those repairs, because that's what it's been trying to do, but it just doesn't have all the material it needs.
This has been so fascinating. It's, every time you talk, it's a new approach in the sense that we just are seeing it from a different perspective. And that's why you're here. And I'm so grateful. And I think everyone really appreciates it. And if you are in the Chicago area, I'm telling you, you should come to our event, because we're going to go into depth with this, with, obviously what we can with bodies that are preserved. But that's the whole point of why you were coming in, was to really to show what we can see and deduce from these structural, anatomical, biochemical, matrices. So
Yeah. And
yeah.
if you have more specific questions, just you can reach out to me, do virtual sessions, or, just give me a shout out. You can get my website, mandalaawareness.net. I'm one of the few Bereans in the book. So if you just search on Matthew Berean, you'll have no trouble finding me.
Okay.
If I'm happy to help in whatever way. So just reach out, and, we can find somebody either, locally, or if you happen to be in the, Michigan, Midwest area, then, might be able to do something in person too.
Well, I hope that, okay, so we've been put into another way.
No, mandalaawareness.net.
I
Yeah.
know, I said,
Yeah.
I messed it up. The second one, everybody. Okay, well, this was super interesting. Thank you again. Thanks for coming, everybody. Thanks for this special event. And it's pretty late where you are, so I really appreciate it. Thank you, Matthew.
Happy to help. Yeah. And we'll see you guys in Chicago.
Yeah, and if you have any questions about that, please reach out to me. I hope I see you. And yeah, Sam.
It was a lot of fun last year. I mean, it was a hoot. It was just great to see people in person, and, and all the presentations we had. It was cool. I had a good time last time. It was fun. And anytime you get a chance to get in the lab, it's just so cool.
It really is. It's so cool.
Get the whole brains.
All right, everybody. So good to see you. I'll see you if you're in the Clatch, I'll see you on Saturday, and we will have Barbara Green and everything else. So thanks again, Matthew. This was fantastic. Really appreciate everything you do. And I just wish there were more of you. That would be really helpful. Okay. All right. Bye, everyone. Thanks. Bye.